My name is Peter van der Kerkhof. I'm a professor of dermatology, a senior professor of dermatology at the Radboud University Nijmegen Medical Center in the Netherlands. What we have done during the last 30 years is dermatology and education in dermatology, but also research in dermatology, and with a special focus on psoriasis. And I've contributed internationally to several organizations, including the European Dermatology Forum, the European Academy of Dermatology, and the International Psoriasis Council. And it is a pleasure really to be here together and to discuss around psoriasis together with Professor Mann.
Thank you, Professor Peter. It's so good to see Professor Peter in AAD. I think it's a very precious chance for me to talk about psoriasis with Professor Peter. My name is Xiaoyong. I'm from Second Epidemic Hospital, Zhejiang University. I'm from Hangzhou, it's very close to Shanghai. Also, I'm a dermatologist. I majored in dermatology, skin disease, especially in psoriasis, clinical research and basic research. I do hope that through the deep research on psoriasis, one day we can cure psoriasis, maybe. Okay, Professor Peter, I also have one question that is confused me a long time. Because when we use biologics to treat psoriasis, for example, when we use R17 or R23 inhibitors, maybe we can inhibit the Th1, Th17 pathway, but this may make the immune to shift to Th2 pathway.
Yes.
So the name of this phenomenon, what's the name of the phenomenon? It's from
yes, it is the immune shift.
Immune shift.
It is extremely interesting on one end and important for practice on the other end. In earlier days, 30 years ago, we said that atopic dermatitis and psoriasis are totally different diseases, and you never will see them occurring together in one single patient. But we learned that that is not true, and especially we learned this during the treatment with anti-IL-17s, also with the anti-TNF. We have seen there patients who had plaque psoriasis and then suddenly developed actually atopic dermatitis.
So, yes.
And that atopic dermatitis is Th2 disease. And also we have seen in the same patients also atopic dermatitis lesions and psoriasis lesions. It is really a problem which you frequently will see in clinical practice.
Yeah.
And the classical idea of that psoriasis is totally distinct from atopic dermatitis is not true. Actually, there is transition possible from psoriasis to atopic dermatitis and atopic dermatitis to psoriasis. Also patients with atopic dermatitis who get then treatment with dupilumab, these patients may develop psoriatic plaques. So my experience is that I see this in clinical practice and that I have to understand the mechanism in order to be able to choose the right treatment. You have a similar experience?
Yeah, sure. Because China, reciprocal is very popular, and for our 17 inhibitor, that is very popular in China. But when we use the IL-17 inhibitor, we found that is the patient get itching and eczema and maybe switch from psoriasis significant to atopic dermatitis. Just as you said, that is immune shift from Th1 or Th17 to Th2. Another thing that we also meet in China, that some patients, they both have atopic dermatitis and psoriasis. It's a paradoxical to the previous conception.
Yeah, immune shift and paradoxical reactions. That is, paradoxical is that something happens which you do not expect. It is the reverse. So you give a treatment for psoriasis and you get psoriasis. That's true paradoxical.
Yes, great.
For example, in a patient with rheumatoid arthritis, patient without any skin lesion, when the patient gets an anti-TNF, it can be that in that patient just psoriasis appears. And that is called a paradoxical psoriasis, for you don't expect that. But when the patient has psoriasis, and you give that patient an anti-IL-17, then it shifts to another phenotype, that is a Th2 phenotype.
Yeah.
And you see atopic dermatitis, and then you call it immune shift. So it has indeed different names in this respect. But a question to you is, I do not know the answer actually. A lot of research at the moment is done on immune profiling in psoriasis, in atopic dermatitis, but also in paradoxical psoriasis and also in immune shifts from psoriasis to atopic dermatitis and vice versa. And there are these days simple kits available for measuring some essential aspects. They call that immune profiling, and it can be used actually in clinical practice. It is available in the Netherlands, will cost about €200 per patient, and then you can get an immune profiling.
Yes.
Whether the methods are still well developed and highly reliable, we have some discussion about that, and whether we should do that in every patient, probably not, probably in situations that we are doubting ourselves. But I know also from some colleagues in Europe who do it nearly in every patient with psoriasis. What are your views on immunoprofiling?
I completely agree with you that for the immune profiling of the patient is very important for the choice of the different types of biologics, because we can choose the different biologics to target the most abundant cytokines.
Yes.
But you know that the immune profile is according to the blood or according to the skin is totally different. Although that we say that the IL-17 and TNF3 on the TNF cause the psoriasis, but in fact the blood level, for example, the serum level of IL-17 or TNF3 or TNF, in fact, it's no very big difference between psoriasis patients and normal populations. But in the skin, it's totally different. Yeah. So this is the skin, the cutaneous microenvironment, the different immune profile in the skin, we determine how to choose different types of biologics. Yeah. So in my department, I use the skin, I take skin and separate the epidermis and dermis. According to the epidermal immune profiling, I determine to choose 17 or 23. But also, as you said, that is not, it's definitely impossible that to check each psoriasis patients. Just some patients have a refractory to some type of very specific biologics that we may want to define what's the reason behind why that is, for example, why the IL-17 did not play any role in this type of patients. So we check the epidermal immune profile. We found that in fact it's not IL-17, it's IL-23 or it's 17 or 17F. Both play a critical role in this type of psoriasis patients. So we can choose some very specific biologics for the treatment of this type of psoriasis patients.
I think this is such an enormous progress, huh?
Yeah.
So you also are in favor of doing immunoprofiling when possible and integrate that in clinical practice. I think it's important that we go that way. We see that also with gastroenterologists, we see that also hematologists, they do immunoprofiling, and based on that, they collect experience and they get more insight.
Yes.
It is an additional possibility that we have, indeed.
Indeed, it's just like some hematology, that is also some oncology. They choose the different target surface by the different expression of gene, and also for the DG and also some immune profiling, because it's easy for them, but for psoriasis, according to the blood levels of the some specific cytokines, maybe it's difficult. Yeah. But anyway, you know that for the proteomics and also for the single cell transcriptomics, the progress and also the price maybe have a relatively low level that the patient can afford. Maybe you can do this in the future. Yeah.
I think when we have this more incorporated in our practices,
Yeah.
the prices will go down. For them,
Yes.
when it is used as a routine, these investigations, then it will be commercialized better for lower prices, and we have that then available as modern patient care.
Yes.
Well, thank you so much.
Thank you. Thank you
was
so
great.
much, Professor Peter. Thank you. I think it's a very great chance that to talk about psoriasis with Professor Peter, because Professor Peter is the top dermatologist that focuses on psoriasis so many years and also have so many experience on clinic and also some other researches on psoriasis. So
Thank you
good
so
to see you
much.
again.
Thank you so
thank
much.
you.